Welcome. My name is Mary Jo Murphy, and I am a member of Ian's and also the Outreach Committee who put this together. This is our 13th patient seminar. Why should I be checked for anal cancer and what follow-up should I expect? Excuse me. Try to keep your videos off. If you want to ask a question, please put it in the chat. Or if at some point we're able to unmute, if we have enough time, you can do that. But do keep your camera off and yourself unmuted. Even though I love dogs, sometimes they're busy in the background barking in the middle of these things. And then it'll be recorded so you can watch it later or somebody else can watch it later. This is not intended as a form of medical or healthcare advice. No material presented is intended as a substitute for the professional medical advice, diagnosis, or treatment, and always seek guidance from your medical or healthcare providers before undertaking a new healthcare regimen. And I think part of what this seminar is about is helping you to figure out a way to get through the healthcare system, no matter where you are or what the stage of your disease is. This seminar is in memory of our friend Irma Preciado. Irma was an anal cancer patient. She actually wrote for the newsletter in 2023. So she was very open about her diagnosis and willing to help by sharing her story. She was part of the UCSF women's support group, and we all loved her and miss her terribly. Okay, I don't know who's going first, Michael or Christina, but
Christina.
I'll go first. Give me 1 second. I'm just going to pull up the slides and get them into presenter mode. Hi, everyone. I'm super excited to be here. Mary Jo asked Michael and I to participate in this webinar. And so my name is Christina Brickman. I am originally or traditionally an infectious diseases trained doctor. And I've now been practicing HRA, I want to say, for high resolution anoscopy for about 11 years. And I actually trained under Michael Berry, who is going to introduce himself next.
Yeah, hi, I'm Michael Berry Lawhorn, and actually, 30 plus years ago, I received a phone call that said, hey, you might be interested in what we're doing here at UCSF. And I met Naomi J., who many of you know, and she was quite pregnant at the time and needed somebody to cover her for maternity leave. I said, sure, I can do that for a few months. And a few months turned into 30 years and truly a career passion. So I bring you 30 years of experience of HRA and taking care of patients at risk for anal cancer, and we'll try to get your questions answered.
And so with that, we'll get started. And I thought we could start with a case that, I think is going to show some of the complex aspects of how to prevent anal cancer and what should be done. And so this is a patient of mine. She's a 72-year-old woman. She has a remote history of abnormal cervical cytology. She recalls getting that frozen off many years ago. And then she developed anal discomfort, and she attributed this to a hemorrhoid, but it didn't go away. And so eventually she underwent an exam under anesthesia because she started bleeding. And she was noted to have, during the surgery, a 1 centimeter nodule in the right anterior anal canal that was removed. And so the biopsy showed something called high-grade squamous intraepithelial lesions with features suspicious for invasion. And she was tested for HPV, and it was positive for HPV 16. And so after all of this, she was referred for further evaluation with high resolution anoscopy. And I don't really know, obviously anyone in the room, but I suspect the story isn't totally unfamiliar of undergoing a colonoscopy or undergoing a procedure and then having something that sounds really scary found and then being sent to someone you don't know to discuss it further. And so really what we were hoping we could do was talk a little bit about what the risk factors are for anal cancer, what some of the symptoms are of anal cancer, and also understand the evaluation that happens when you have anal cancer or anal precancer. And we're going to try to keep it not too detailed so that it's interesting, but also so that we have plenty of time for questions afterwards. So, oops, sorry, my bad. So anal cancer arises from the most distal part of the digestive tract. So the part closest to the outside. And we now know that 90% of anal cancers are associated with infection with human papillomavirus. And human papillomavirus, or HPV, is a sexually transmitted infection, and it can cause cancers at different sites of infections. And so, we think about it classically with cervical cancer. Most anal cancers are caused by HPV 16. And so here I don't know if people can see the cursor or not, but on the right side, I have a sort of a description of how I think about the anal canal. And so on the top is the rectum, which is part of the sort of large intestine. And so that's where you can get colorectal cancers, which are not related to HPV and more associated with age. And then you have the anal canal. And then on the outside is what's called the perianus, which is also caused by HPV and in many ways treated similarly. So often when we're referring to anal cancers, we're also including perianal cancers. Anal cancer is pretty rare in the general population. However, the rates of this can be quite high when with people with certain risk groups. And that is what this graph is trying to show. And on the left side is the rate or the incidence. And then on the horizontal side, you see the different risk factors. And so you can see, the more red it is, the higher the risk. You can see that having HIV, so living with HIV is an important risk factor. MSM means men who have sex with men. It's perhaps a little bit of an outdated term, but that is also considered a risk factor, and then a history of prior gynecological, either cancer or precancers, and other immunosuppression. So basically, if your immune system doesn't work for whatever reason, you are at higher risk because you're not going to control the HPV virus as well. And so that includes people who have had, for example, transplants. And so this gives us a way to think about who might be at highest risk. But the truth is that many people who get anal cancer don't have any risk factors because the overall biggest group is women without risk factors. And that's just because there's a lot of women in the world. And it's important for us to think as we move forward of ways that we may be able to further identify people who are at risk. So where does the rationale come for anal cancer prevention? So similarities exist between cervical and anal cancer. And cervical cancer is, the cervix is part of the uterus in women. And so they're both caused by persistent infection with human papillomavirus. And they both have the same precursor lesion, which is high-grade squamous intraepithelial lesion. So this mouthful, or HSIL, means pre-cancer. That's a precancerous lesion. And so we know from cervical cancer that if we detect and treat the precancerous lesions, we can decrease the risk of cervical cancer. And so can the same concept of finding anal precancers and then treating them be used to prevent anal cancer? And so that is what a lot of what we do at our high resolution anoscopy clinic. And there are two key procedures that I'm going to touch upon that we do in our clinic. So one is the digital anal rectal examination. And two, something called high resolution anoscopy, which you may or may not be familiar with. So the digital anal rectal exam. So the traditional nomenclature was, I think traditionally was like DRE, digital rectal exam, but we threw an A in there because we think it's very important to appropriately examine the anal canal with your finger. And so what it involves is palpation of the entire anal canal, as well as visualization and palpation of the perianus. And what that allows you to do is with your finger, you can palpate abnormalities that then may require further evaluation. And this includes early cancers that may not have any symptoms yet. So in our clinic, everyone gets a digital anal rectal examination, and we're looking for abnormalities that might be concerning for cancer, amongst other things. And then we do something called high resolution anoscopy. And so what is high resolution anoscopy? And so on the right, you have my colleague, Vishaan Patel. And this picture I've now shown like multiple times. So I feel like he's becoming a celebrity. He doesn't mind. It was even in the like UCSF newsletter at some point. But what it is, it's a technique to examine the anal canal and the perianus using a colposcope, which is a type of microscope for lightening and magnification, after application of acetic acid, which is vinegar, and Lugol's iodine to identify lesions. And so this is an example of a setup in one of our clinic rooms. And so you can see the exam table. And on the left is the colposcope, which is a type of microscope. And on the right is a tray where, you know, we would have our equipment, and then we have a screen where we're able to see the images that we're capturing, because we're often taking pictures for patients' cases. This is an example of our tray and the instruments we use. And so it's anoscopy because we use that plastic tube that's right in the middle to look on the inside. And it's high resolution because we're using the microscope. So this is a picture of what we see. This is normal epithelium. And so you can see kind of in the center is this darker pink, which is the rectum. So it's the end of the large intestine. And then on the side, that's like a little pinker and more white, is the anus. And where they meet is called the squamocolumnar junction, because it's two different types of tissue that are meeting. And that's where we get a lot of high grade, that's where we get a lot of cancers. And so this is an area that we examine very carefully to try and identify either precancerous or cancerous lesions. And so here's another picture that's normal. So we use both vinegar to help us see lesions. And the vinegar is going to make things more white, especially if there's an HPV associated lesion. And then we use the iodine, which you can see on the right, to also help us. And when the iodine stains nice and dark brown like this, that's totally normal. So we're looking at normal tissue right now. And here's an example of a high-grade squamous intraepithelial lesion on the left. And so we're trained to recognize these. And you can see kind of these lacy pattern and feathery borders. And I think it'll become more clear here. And then when we put the Lugol's iodine, it doesn't pick it up. So it's Lugol's non-staining. So the point here is that you can't really identify these precancerous lesions without the magnification and the acetic acid. So if a provider's not doing all of this with the microscope and the vinegar and the iodine, they are not going to be able to reliably find the precancerous lesions. And then once we find the treatments, once we find the lesions, we figure out how to treat them. And so there's a lot of ways to do this, but one of the most common is office-based ablation, which means that we will superficially burn the tissue. And here are just some examples of that. So on the left, you see a lesion, and on the right, it looks charred because it's been burned. And here's an example on the perianus. So on the outside, again, on the left, you see a lesion. You can actually see how it's kind of whiter because of the vinegar. And then on the right side, it's been treated. And we now know that our treatments actually work. So we did this really, really big study with almost 5,000 participants and of people living with HIV who had these anal precancerous lesions. And we actually showed that treating decreased the risk of anal cancer, which was very exciting for us. And Michael was the protocol co-chair of this study. But, you know, it validated a lot of the work that's gone into it. And so there's a ton of interest in identifying people who may be at risk and preventing anal cancer in them. So given all of that, back to our patient, we know that she had at least a precancer that was removed. But the pathology said some things about, some of it might be concerning for cancer. And we know that there's HPV-16, which, as I've mentioned, is the type most closely associated with anal cancer. So for me as a provider, if this patient's coming in, I'm going to think, well, is there cancer there that's been missed? Is there leftover precancer that hasn't been removed? And how is this going to affect the management? And I'm going to pass it on to Michael, I think, next to discuss this next topic. You're muted.
Thank you, Christina. That was a great introduction. So I thought we would compare what we do with HSIL versus cancer to just give you some comparisons. So in the left column, I'm going to talk about what we do to treat HSIL or precancer. It can be removed to prevent cancer, as you've heard. We usually treat it by destroying the lesion with electrocautery. If it's not adequately treated, it may progress to cancer. And radiation and chemotherapy are never used to treat precancer. At least they shouldn't be. Cancer, on the other hand, requires tests to, by definition, cancer has a capacity to invade locally into local structures and spread to other areas of the body. So when we diagnose a cancer, we have to do tests to make sure that it's localized or to find out where it's spread to. If it's spread to local lymph nodes, those can be included in the radiation and often are eliminated when it's treated with radiation and chemotherapy. The very, very smallest cancers that we call superficially invasive cancers, which we don't find that often, but we do, and when we do, they can be cut out. But they have to be really small. So by definition, they're less than 6 millimeters across, which is less than ½ an inch. And they also can't be very deep. Now, if we cut those cancers out, normally, like I said, we treat cancer with radiation and chemotherapy. So if we're not going to give radiation and chemotherapy, then if your follow-up must include, ideally, high-resolution anoscopy, because we know that most people who have these early cancers have other coexisting areas of precancerous spots. And then if we don't treat those spots, you know, they could potentially turn into other cancers. And again, cancer is potentially curable when treated with radiation and chemotherapy, and that's super exciting. Next, please. So now I'm going to switch to talking about how we do follow-up, and I'm trying to sort of address some of the questions that have been raised. But I'll have to kind of look at my notes to see how we do that. Anyways, so with HSIL, after we do a treatment, we usually have somebody come back in 4 to 6 months. 4 months or even 3 months if they have a lot of disease and we didn't think we got rid of it all. 6 months if it's fairly straightforward and we're not too worried about them. It's really common for additional treatment to be needed for many people, not everybody, but many. And the follow-up and treatment that's guided by high-resolution anoscopy is likely better than no high-resolution anoscopy. And the reason that I say that is mostly based on experience. I mean, we don't really have any data, but over the years at UCSF and even now where I work in Las Vegas, we've seen a number of cancers, and 4 of the 7 cancers that I've seen were in care by local surgeons. And whatever the approach was that these surgeons were doing, it wasn't eliminating these people's precancerous lesions, and the follow-up wasn't intense enough to prevent them from getting cancer. We'll talk a little bit later, I think, about, well, what do you do if HRA is not available? But let me kind of continue on and we'll get back to that. So for cancer, when radiation is not required, again, as I mentioned, we have to follow people really closely every 4 months for the first 2 years with aggressive treatment of any of the precancerous lesions. After radiation, we kind of end up doing the same thing. We see them every 4 months, and when we do, the follow-up is with the same thing that Christina mentioned. We do cytology, we do a digital anal rectal examination, and we feel the groin areas for inguinal lymph nodes, because those are the nodes that we can feel, and at least for cancers that are located more distally in the canal, that's the area where they tend to spread to. We also perform high-resolution anoscopy as well, too. And, you know, I have to say, if you've been treated for cancer, somebody needs to be doing this. Ideally, if you don't have access to high-resolution anoscopy where you live, then at least your radiation oncologist or your medical oncologist will be doing this. However, I know it's relatively common for a lot of people to go in and see their docs or providers and not have this done. So it really is critical. And the reason that it's critical is, even though I said that most people are cured, we know that most of the recurrences, if they're going to occur, happen within the first 2 years. That's why we make the treatment more, or the follow-up more intensive. So if that's not available, then I think the next best thing is to at least have anoscopy, perhaps maybe see if the radiation oncologist is uncomfortable doing the digital exam, then maybe going back to the surgeon. Next. I think I'm done. Yeah, back to you.
All right. We do have a question in the chat about experience in transplanted people in HPV 16. So people with transplants, and by this, you know, we're usually referring to what we call solid organ transplants. So, you know, lung, heart, liver, kidney, are at higher risk for anal cancer. And there's like quite good sort of population level data to show that. And these are patients, especially if it's been a while since of the transplant, we consider them quite high risk, because after 10 years, it's actually the risk goes up by a lot. And I don't know, in my mind, I want to see them before that, because I think it's easier to get a handle on things. Whether their cancers are mostly HPV 16 or not, that's a good question. And I don't know off the top of my head. I would assume so, but I actually don't know how convincingly that's been answered.
I don't either.
All right. So with what I just said, I am going to wrap up this patient's case. So basically, I met her in clinic. I did an exam. And so just as a recap, she had this nodule that looked concerning, and then the path actually was also concerning, but not diagnostic of cancer. And when I saw her, I saw a lot of leftover high grade, like a lot, a fair bit. And that's not uncommon because, again, we're really able to visualize things well. And there were some changes that I thought maybe were an early cancer. So we decided that she was going to go for additional surgery because one of the things that we're trained to do is to never treat something that's precancerous unless we're confident that it's not cancer, because otherwise you're just delaying someone getting their chemotherapy and radiation, which is what they really need. And so we're actually able to do HRA-guided surgeries. So we bring the microscope into the OR and we find the lesions. And so she had that area excised again with this. And interestingly, the pathology didn't have cancer, but again, seems suspicious for cancer. So after all of that, I felt like we had done our best to try and find cancer. We hadn't found it. So we didn't see a clear indication for chemotherapy and radiation. But she was someone that maybe was close to that early cancer category. And so basically I watched her like a hawk. And we did several additional treatments of her precancerous lesions. And she's done really well. And her HPV-16 testing is now negative, and I have at this point spaced her out to every 6 months, and she's doing great. So that, I think, was for us to kind of put in perspective what we're doing and the things that we're trying to do and sort of learning about in terms of preventing anal cancer. And we wanted to make the next part a little bit more about the patient and what are some of the things the patient needs to know and ask about in order to be able to advocate for your health. And I think this part's for you, Michael, or is it, or?
I think you start.
Oh, this is me. Okay. So one thing I wanted to bring up for people to know is that we actually now have guidelines about screening, and this is a relatively new thing. They were published last year in 2024. So we have the two sets that at least I'm bringing up is the International Anal Neoplasia Society consensus guidelines for anal cancer screening. And those are for everyone. And really, they're trying to identify at-risk people who might benefit from screening. And then the other sets of guidelines are for people living with HIV, and thereby the Center for Disease Control, or the CDC. And so you don't have to know all the details, but just to know that the guidelines kind of specify when people should be screened and what age you should start with. And for the majority of people, it's at age 45. But if you're living with HIV and are male having sex with men or are a transgender woman, you start a little bit earlier. So I don't need people to memorize these. I just want people to know that these guidelines now exist. And if there's something that doctors like, it's guidelines, because it tells them what to do. So these are some of the things that I think is important for that patients can do. So one, if you have risk factors for anal cancer, or someone who has risk factors for anal cancer, your first step is going to be your PCP. And they may not even be aware of these guidelines. And so it's not, a bad idea to just be like, hey, look at this, it's been recommended. What do you think about this? And most providers will at the very least be interested and should want to learn about it themselves. The other thing that I will say is that anal pain or discomfort needs an exam. And the number of times that we have heard of people having anal pain or discomfort and then being told it's a hemorrhoid and nobody's looked at it is high. And, you know, I feel like if your elbow were to hurt, someone would look at your elbow, but obviously looking at the anus is a little more complicated. But I also think it's totally reasonable to be like, hey, I'm worried about cancer, and I'd like someone to look. And if a doctor, again, if they hear the word cancer, that's like the one thing they really don't want to miss. So it's totally fair to put it on their radar. It's just not on their radar. It's not that they don't want to do the right thing. And then if you have anal precancer or cancer, I think it's good to get a second opinion. And this can be a little bit tricky depending on where you are, but second opinions are good clinical practice. It's not insulting to the provider. You know, we expect them, we accept them, we think that we're always going to have something perhaps to learn. And especially in cancer cases, they're increasingly common. And then the last thing is usually these cases are not a one-time visit. And so it's important to know where to follow up or what the follow-up is going to be. Ideally, it is a center that has the capacity for high-resolution anoscopy. But those are the things that I think are important for patients to be aware of, so they can, you know, push a little bit here and there. All right, now it's Michael.
Yeah. So how do you know whether your provider does HRA? I mean, I speak to new doctors that I work with, new surgeons sometimes, and I say, "Are you doing HRA?" "Oh yeah, I do HRA." And I even had an experience where one of my women went to see the gynecologist to look for vulvar disease. Did they use a colposcope? Well, not really. He had these things on his glasses. So it's important to be aware. It's a fair question to say, "Oh, you do HRA? That's fantastic. I'm really interested in finding somebody. How often do you do it?" And if they say, "Well, I see 2 or 3 patients a year," that's not really the person that you want to see. Ideally, you know, I would say most of us who do HRA on a full-time basis, at a minimum, see 8 or 10 a week. Sometimes it's only 4 a week, depending on how busy someone is or how experienced they are. It's a fair question to say, "Hey, have you ever seen anal cancer? How many have you seen or treated?" It's funny, I gave a lecture today to some local residents, and some of them rotate through our clinic, and there were like 30 people there or so. And I said, "Well, who's seen anal cancer? Raise your hand." And the only 2 people who had seen an anal cancer in that whole group of people were people who had rotated through their clinic and worked with me. It's also okay to say, "Well, how did you get trained? Did you learn this in your medical school, in your fellowship, or in your residency?" The reality is, although people say that they learn it in their fellowships and their residency, there may be some places, I won't say none, where they do it, but it's not to the same degree as when we put on our courses to really train people. We also have put on some mini courses for the colorectal surgeons, which is just like a half a day or 6 hours. We now have a virtual course, which actually is pretty intensive and is probably equivalent to the 3-day course, except for being able to work together with people. And then did they get an opportunity to work with an expert? And did they just watch them, or did the expert watch your provider perform HRA? Not everybody has that opportunity, and it doesn't mean that they don't know what they're doing. And then there's a new thing coming out that Ian's is sponsoring called certification. And it's okay to ask if they're a certified HRA provider. A number of us folks who have been there at the beginning are beginning to actually go through that certification process. And then for your resources, if you look on the Ian's website under the patient section, you can find providers in the United States that are listed. Unfortunately, we can't say anything about really the quality of they do. We really just know that they say, yes, that they performed HRA and they're willing to see patients. And I think that was all I had to say about this. Yeah.
Yep. I think that's all we had to say because we wanted to make sure that we had time for questions from people.
So we have quite a few questions that came in ahead of time. If anybody has questions that we don't address, feel free to put them in the chat. And Dr. Mary Birdsall was one of the people who helped us with this from her own Facebook group. So if anytime you want to jump in, Mary, feel free. You did a great job of covering a lot of things that were on the list of questions. I think one of the ones that I'm not sure how much we covered, but what kinds of effects can I expect from the treatment and how long will they last? Can the effects be treated? So that's a huge one.
Well, I guess we're talking about either treatment for cancer or treatment for precancer. Since we talked about both, the treatment for precancer is pretty straightforward. Most people will have a little bit of discomfort or burning with bowel movements that lasts a few days. If they have very, very extensive lesions or they've been treated in the operating room, it may last a week or two. The radiation and chemotherapy, because it's destroying the abnormal tissue, in the beginning, it's not so bad, and people think, oh, this isn't so much of a big deal. And then as it becomes later on in the treatment's about 5 weeks long. The effects of destroying that tissue begin to manifest themselves, and people have what they call a radiation burn there. And that has to be managed by, and somebody asked about a fissure and ongoing pain after chemoradiation. So it's really, I mean, bowel care is essential for all of us. And so keeping up with the fiber, drinking lots of fluids, making sure that we go on a regular basis and that things are relatively soft and moving is the best way to kind of avoid any problems. And that's probably, I mean, the radiation oncologists are experts at managing the skin reactions, and they have all sorts of potions and creams that they prescribe. And I would say, although people are not happy with how they feel at the end of radiation, within a few weeks, maybe a month or two, they begin to feel substantially better. Christina, you want to add anything to that?
Yeah, I think so for the anal cancer treatment, you know, we send our patients for radiation, for chemotherapy and radiation, and then they come back to us afterwards, right? So, and usually it's maybe somewhere 8 to 12 weeks after completion of chemotherapy and radiation. So we don't see the most acute phases, but we certainly see the more chronic phases. And I would say it's very variable on how people do. And I think one or the two biggest things are bowel continence and bleeding, because you can get radiation proctitis, and so you can have bleeding. So for bowel continence, it sort of depends on how much it's bothering the patient, to be honest. But, you know, like sometimes I do have to press a little bit because someone will be like, no, I'm fine. And then I'm like, okay, yeah, I'm fine as long as I don't leave the house, right? And so that, you know, we want quality of life to be good. And so the two things that I sort of harp upon is like, good bowel regimen so that stools are soft, but formed, right? Because, and often fiber is a part of that because you don't want things to be too leaky. That's hard for the muscles to hold it up. And then the other thing is strengthening the muscles. And that's where like pelvic physical therapy or pelvic physiology come in. And I think pelvic physical therapy is great because it really can train people to strengthen the muscles. You can strengthen the external sphincter. You can, that's the muscle that like when you really need to go to the bathroom and hold it in, like that's the one that you need. But the issue with pelvic physical therapy is like it takes a lot of work. And so if you have mild symptoms, it's not going to happen. But those are some of the things that I talk about. And then for bleeding, patients can get argan plasma coagulation, which is basically like the gastroenterologist goes in and they kind of like paint this on and it helps coagulate the big blood vessels. I've actually never seen it, but I've heard good things. So yeah.
Should we take some questions that are in the chat?
Yes, please do that.
Okay.
All
So
right.
question about Gardasil vaccination, particularly in younger men. I guess older men really, over 45 who may never have acquired HPV-16. I think that's a difficult question to answer in the sense that there are some people who definitely kids need to be vaccinated. And if we vaccinate the kids, we'll get rid of this disease. So let's just put that out there first. I think the vaccine was designed in such a way as to really be preventative and not so much therapeutic. We don't know is the answer. My own experience in seeing people who have been vaccinated is, I can't tell whether it helped or not, although there are a couple of published papers that say that it decreases recurrence. Although I think it's interesting that the pharmaceutical company that stands the most to gain from making a formal recommendation of that has never sponsored a study to prove that fact. So I'll leave it at that. I don't think it's going to hurt anybody. And I think if they're under 45, I encourage people to get vaccinated. Over 45, it's really hard because the pharmacies have protocols and they won't vaccinate people. So we've had, if they're over 45 and they really insist on being vaccinated, we've had to have people bring in the vaccine and give them the shot in the clinic. Should we just go back and forth or?
Yeah, I can take the next one. Although I might need your help with it too. So
Okay.
how often do solid organ transplant patients need anal cytology screening? If normal and no high risk HPV, should it be repeated every year or every 2 years? And what I don't remember is if the EANS guidelines actually comment on the interval for follow-up, because I don't think this is something that we really know or that's been well established. I think for the most part, consensus is a year, every year.
Yeah, I would agree. I mean, you
Right.
can take some clues if people had either for women, if they'd had lower genital tract neoplasia, and might see, definitely err on a little bit closer interval, or if they'd been treated for anal warts when they were younger, I might err on. And so conversely, if they didn't have any of those risk factors and it was a cold negative, it has to be the right HPV test. There are two main tests in practice today. One is what we call polymerase chain reaction or PCR, and the other is and that tells you whether there's HPV DNA present or not. It's the most comprehensive. The other test is something that goes by the trade name Aptima, and it looks at RNA. And the deal with RNA is it indicates that the virus is actively replicating and producing RNA. And that may be a better way if I don't know that it's the best screening tool to use, but I would say that most of the people who are RNA positive often have worse disease. So it is a good indicator in that regard. It's not a good indicator if it's negative.
What's the next question? I can take it if you want. Do you think all surgeons finding HSIL refer patients for HRA? And if not, how can this be encouraged? No, I don't think all surgeons do. I think it depends a lot on where they are geographically and what their exposure to HRA has been. And also like what they have access to, right? Like they may not. So I have seen the whole gamut of things. I've seen patients get referred to me. I have seen patients get no follow-up. And then I've seen surgeons who actually will follow up the patients themselves with what we call standard endoscopy. So it's the anoscope, but not the microscope. And so that's probably reasonable in terms of finding cancers or like something major. It's not as good as HRA for the precancers, but you know, if you're in like a really, really limited resource setting, it may be what the surgeon's doing. And in terms of how to improve it, I think we need more education. There's actually a lot of interest recently from the colorectal surgeons about HRA, and so we are, I think, making progress. We actually have had several of the surgery residents, for example, here at UCSF just rotate with us because they're interested. So yeah, we're trying to spread the word, basically.
Yeah, I think I agree. We have work to do within our society, and both in terms of publishing some of the data we have to try and encourage the referral whenever possible for HRA. You know, I also think that maybe my dream is that there will be centers of excellence geographically. They still won't be, you know, they won't be close to some people, but at least people will know where to send people if they have a problem.
I just
I
wanted
will.
to say too that one of the things that comes up is that no one owns this area. This is a multidisciplinary approach. Ian's has many different disciplines, and so I think it might be confusing for patients to know where to go. And that's part of why we're talking about this today, but there aren't centers for this except maybe UCSF. So just a thought.
No, an important one. In terms of treating with laser versus electrocautery, I've actually done both. When I was at UCSF, I worked with a gynecologist who did laser ablation. I did several laser ablations with her. I frankly, I don't think the laser is any better than the electrocautery. I think what determines the efficacy of the treatment and the sterilization is how well you do your HRA. If you do good HRA, use good magnification, lots of vinegar, and look carefully, and really go after all the disease, you're going to get rid of it. And I think that's what happens with some of the surgeons who don't do HRA. They see a little something, they don't have vinegar on it, or everything looks white. It ends up being a problem. Another question, is it standard to use retroflexion to occur at the time of colonoscopy, as this is a good screening tool for women at low risk? The last time that I inquired about this, I talked to a colleague of ours who's a gastroenterologist in Washington, D.C. And I've looked at the formal protocols for colonoscopy, and retroflexion was not required. It's recommended. I think you bring up a good point, and I think as we try to figure out how to expand the workforce, I think we need to partner better with our with our gastroenterologists who are doing all these colonoscopies, or maybe even convince some of them to maybe put a swab in and do some HPV testing before they do their digital exam. But I think it's an area where we have more work to do. Christina?
Yeah, I mean, I agree with that statement. Let me see. Emily said, thank you. And someone was able to get vaccinated in their late 70s with no issues. And then Jenny's commenting that they're about a case of Preciska. Any topical prescription or over-the-counter recommendations for chronic perianal irritation after laser procedure for warts treated years ago?
Can
I go?
Yeah,
on
go
this
ahead.
one? Okay. Although, I have a whole thing on perianal irritation, and it can be really tricky to manage. It can be very chronic, and it's hard to know what caused it, because it may not have been the laser procedure, especially if it was like years and years ago. Like usually the skin should heal. So first thing is someone needs to examine the area, right? We want to make sure that there's like nothing really obvious, like a herpes outbreak or something like that. Clearly, if this is chronic, it's less likely. And then I sort of think about, like, is there like a superficial fungal infection, right? And then you can just give someone an antifungal, it'll go away. Or is this just like a chronic, what we would say, dermatitis? So chronic irritation, right? And most of the time, or a lot of the time, that can be caused by wiping and scratching a lot, because what happens is it itches. Patient thinks it's dirty, so you're going to go and clean it. And what that actually does is it takes away kind of like all the protective oils or on the skin. And what does that do? It makes you more itchy, and you're going to go again and scratch and clean again and clean it again. And so it becomes, we call it the itch scratch cycle. And so you have to break it. So we tell patients a couple things. One, if you're using wet wipes, you should stop because they have a common preservative in it that can actually cause a dermatitis. So we say no wet wipes. Two, you're actually going to wipe less than you're wiping, and you're going to do so very gently. And so, you can either like use a bidet, you can jump in the shower, and then Michael tells them to put a little bit of Curel on the toilet paper, Curel
Clean with a
moisturizer.
Curel, yeah.
Huh? Yeah. And
Clean
actually
with it.
that works well. I also tell patients, like, if they're scratching at night, you can take like something to help with itching at night and put gloves on. And then sometimes we use steroids. And what steroids are there for is not to be used long term. It's to really give you enough relief from the itching that you're going to stop scratching. And then we sort of, and I would say, I don't know, 8 times out of 10, we are successful. And after that, it can get a little bit tricky. And then in terms of specific creams to apply, I'm going to let Michael do that one, because I know there's different ones you've tried over the years.
Yeah, I think Jenny mentioned using zinc oxide. I think barrier creams are helpful. Just plain Vaseline also functions as a barrier as well too. I think other than that, there's another one called Anal Pram that I haven't used very much. Mostly what I try to do is exactly what Christina said. Try and get people to not be creating the problem. So either rubbing too hard with dry toilet paper, or washing too much, or using wet wipes. I'm going to go on to the next one from Faline. Interesting question. Having more than 4 lifetime sexual partners is a risk factor for acquiring HPV. When should the people in this demographic ask for DARES or anal PAPs? I think if we consider that 85% of the sexually active population has been exposed to HPV, then we would say everybody. So I think that doesn't work. I will say this, I think we need to encourage our colleagues to abide by the guidelines, to not screen younger people, younger men who are at risk, to not screen younger women if there's not an indication. Again, we're talking about asymptomatic people here, people who are not having any pain or bleeding or itching or anything, that we're just trying to figure out whether they have problems. Because there isn't the capacity to follow up with them for the high resolution anoscopies. So when should they ask? One of my pet projects, or I should say, now that I'm retired, pet projects that I wish somebody would adopt is to kind of tackle the issue of the growing numbers of anal cancer in older women, 65 and older. And I really feel like now that we have some data that we can prevent cancer, that maybe we could be doing something with HPV testing it. And I would do that only probably after age 45.
We're down to our last 5 minutes.
Yeah.
Maybe 4 minutes, but so I just wanted to thank you. This was wonderful, and you answered a lot of questions without even being asked them, which is perfect. This may be the first of 2 of these, depending on what kind of feedback we get, because I do think you've given us a lot to work with. And I think it's important to know that there's more work to do in this area and that it's being done. And so anybody who's interested in and as a physician or a practitioner or a patient who wants to be an advocate, you'll learn a lot just by being part of this organization. I also feel really strongly, and Mary has left, but I think patients have a real opportunity to push their doctors to learn more, to know more. So you were given some guidelines about what to ask and how to ask it. But I think the more patients who ask for HRAs, the more doctors are going to get trained because it's not on everybody's radar, but there's definitely now a system of training and that's happening with Ian's and in different areas, medical institutions. And I think it's okay to ask and don't be put off if somebody says, well, I don't know, because saying I don't know is a good start to them knowing. So anyway, and make sure too that if the person you're seeing is afraid to examine the area, it's not the person you should be seeing. They need to be okay with the anal canal.
And I would say, sorry, I know we're tight for time, but
Nope, okay.
sometimes it's not that they're afraid, it's that it takes more time. And so you can also be like, okay, but if it still hurts in 2 weeks, can I come back and we'll do an exam then?
Right.
And that should take care of it. I don't know.
Yes, that's great. This will be recorded and it should, Audra, I don't know when it will show up on the Ian's website, but
It should be posted by tomorrow or the next day.
okay. And feel free to tell other people about this because I think this was wonderful. And I really appreciate Michael and Christina doing this at such short notice because even though the outreach committee works very hard, sometimes it takes us a while to pull everything together. So this was terrific.
Thank you for inviting us.
Yes, thank you.
And I think that concludes our patient seminar. And please send us feedback if you'd like.
All right. Bye, everyone.
Be well.
Bye.
Bye.